So today we are lucky over today and tomorrow to have Dr. Dave Davis from the AAMC to be visiting with us as a visiting professor and a consultant to the Med Ed department. So I am going to give a little bit of his background. For those of us in the room who know a bit about continuing medical education, Dr. Davis doesn't really need an introduction, but it's pretty impressive to hear his international reputation. So Dave has over 40 years as a practicing family physician in Canada during his professional career. 30 years of that he spent in continuing medical education and is really an international leader in a lot of the research around this field and now its intersection with performance improvement and quality. He was actually their associate dean at University of Toronto for many, many years, through the 90s and into 2000. I think retired from there and then came out of retirement to go work at the AAMC. He has been on multiple committees. He's on committees all over internationally with Canada and with ourselves, and has had, with CME or knowledge translation, has had over a total of $10 million in grant funding throughout his career, so he's a very impressive CV. He's authored over 100 peer-reviewed articles and has been invited to over 300 talks internationally throughout the world. Currently, Dave is the Senior Director of Continuing Education and Performance Improvement at the AAMC. So I met Dr. Davis last year shortly after becoming dean. Someone gave me an email introduction, and I don't even know if Dave even knows this story, an email introduction, and I was very excited. I said, oh great, the next time I meet him at some meeting eventually, I'll be able to say, hi, I'm the guy they introduced to you from Sinai 8 months ago. Well, it didn't happen like that. He sent back an email almost immediately, and it said, and I quote, it said, great to have you on board. My assistant will be in touch shortly to set up a call for the two of us, and welcome to the wacky world of CME. And so I associate Dave Davis with the word wacky as I now associate CME with wacky. So, but it has been a wacky year, and so I think that what Dave has to say comes true. So I think over the next 30, 40, 50 minutes of interactive work with Dave, I think we should all pay attention because what he says is about to come true. So let's welcome Dave to our Med Ed Grand Rounds.
Thank you very much. I hope you can hear me at the back. So if you know nothing else about me, you know that lectures don't work. Right? So the first thing to know is how you make them a little bit better. Sometimes you make them better by being interactive. So for 2 minutes, I'd like you to tell me what those things are. What's the top left? You've been looking at them for 5 minutes. So point, blank, range. Oh, this is awful, isn't it? Okay, so what's the one below it? Walk in the park. Walk in the park, good, see? You does it, good. Okay, you know this one. There's always something. Okay, top right. Down in the dumps. Down in the dumps. The one below it?
Because we're recording.
Oh, thanks. Okay. Thanks. Excuse me, I'm getting wired here. Any ideas? Eye chart. Right chart. What's this one? Extended contract. Temporary setback. And last but not least, unfinished symphony. You're right. Thank you. Not done. Any question? No. I'm sure if I hit something here, the page will page up. Right? No, maybe this. There you go. So this is what we called these rounds. Your assistant sent me an email and said, so what would we call these rounds? So I called them Not Your Grandma's CME. And then I went on to say the integration and impact of an effective continuing education, blah, 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 blah. And I thought that isn't quite what I had in mind, but it is Not Your Grandma's CME. I'll tell you more about that. This is a better title. I'll tell you why it's a better title, because I think CME is often seen as this sort of experience, this passive seats in a chair kind of experience. when I believe CME can save lives. I believe CME can improve patient care and therefore improve patient lives. And for those institutions that have gotten it, CME is much better, and I believe the institution is much better as a result for it. So this is pretty pathetic at the end of my career not to have anything to disclose. I'd like to have like 4 contracts and a Pfizer thing, but nothing, sorry. So when you think of CME, what do you think of? Sitting here, that's right, for sure. Other things you think of CME? You guys, you think about it all the time. Documentation. Don't you love it? Documentation. Anything else you think of?
Early mornings.
Early morning, yeah, and those old bagels that were left over from the night before. So many people think of it just like this, just like you said, sitting in a room. You can tell that's an old slide, right? Because it's an overhead projector. I used to carry my overhead projector slides around like this. The other thing we think of is this, right? The commercial support, the pharmaceutical company influence is much better now than it was, say, 5 years or 10 years ago. And the other thing people think of is this resort setting. And if I had a credit thing, that credit sort of certificate, I'd show that too. I just don't have it. So that question about what do you think of when you think of CME brings to mind some other questions that I'd like to raise with you. And I'd like this to be as meaningful a conversation for you as possible. Because at the end of the day, David and I have begun thinking with his colleagues, including the dean, thinking about what continuing education might look like at Mount Sinai, at the hospital and the medical school and the medical center. What might it look like? What might distinguish this continuing education presence from anything else, perhaps in the U.S.? So to frame that conversation, I have several questions. Does CME work? How would we know if CME works? A word or two about the clinical care gap, the gap between what we know we should be doing and what we are doing. That's universally. What do we know about effective continuing education? There's a wealth of research about continuing education. There's as much as there is about continuing ed as there is about undergraduate and graduate combined. What are the forces changing CME? It isn't just our wish to change it so that it's better for our practitioners and our patients. There are forces changing it, and we'll review those briefly. And I'm going to go back for a minute here. The last 2 things I'd like to talk about are the AE4Q project. We love acronyms from Washington. I come from Washington, I have acronyms, right? That's probably all I bring you. One of them is called Aligning and Educating for Quality, or AE4Q. And the last is Implications for Mount Sinai. So let's talk about the CME work. This is me. Actually, it's not unlike what I used to look like. The guy on the left, I had hair. I didn't wear my stethoscope around the neck. That's a relatively new phenomenon. But this was my dean of the day, and he actually looked a little bit like this, which is why I picked this picture. So I think it was sort of like day 1, and I was on the wards, and I had just been appointed the director of CME. And I said to him, what do you want from CME? What is it that you expect CME to do? And in my mind, I had 3 or 4 ideas. One was to improve the reputation. This was McMaster Medical School in Hamilton, Ontario. And I thought maybe to increase registrations, improving reputation. I thought it would have to do with referrals and maybe revenue. And he said those are all nice things, but that isn't what I want.
Dr. Davis,
yes.
when you place your watch next to that lavalier, it gives off a...
Oh, thank you. I'll just put it down here. How's that?
Something like
That's right. Thanks very much. So he said this. Does CME change physician behavior? Does it change healthcare outcomes? I just want to pause for a moment. For those of you who are faculty here, the power of the timed phrase, the question, this changed my career trajectory. This little conversation in the hallway, not unlike this, I bet you every single one of us in this room has had some encounter like that. The power in that 2-minute conversation, that built a research career and built a better understanding for me about continuing education, beginning with what he may have forgotten by now was an innocent question. But that's what he meant, and that's what I mean when talking about continuing education. So I just wanted to picture for you something about the size and scope from the Accreditation Council for CME of continuing education in the US. This is a year out of date or 2 years out of date. 133,000 accredited activities, that's accredited, with almost 1 million hours of instruction, applying to about 10 million allied health professionals and 15 million physician participations. Not that there are 15 million physicians, but 15 million physician participations. With that breadth of continuing education, all of it accredited, all not so much aligned with commercial support, you might expect that we would have better clinical outcomes. And every one of us knows that they shrink in comparison with the discussion of the clinical care gap. So I've just picked 4 pictures to exemplify. Every one of us in this room has examples of clinical care gap. It might be, we lived through in the University of Toronto and Toronto generally, we lived through SARS, where there was a failure on the part of public health to communicate the risk of SARS, a failure for us. Many of us deal with diagnostic imaging and know in this country and in Canada there's huge overuse and underuse phenomenon of it and many investigative techniques. Many of you work in the emergency department and know daily about the gap between what it is we should be doing and are doing for a variety of reasons. And lastly, the notion of patient-centered care, the thought that the patient needs to be at the heart of his or her treatment, this shared decision-making ideal for which there's pretty good evidence of effect, is something that we fall short on. So this comparison, I've shrunk this little circle because I wanted you to see as I do that that's a pretty small thing. So there's something wrong. Here's another way of looking at something wrong. This is expenditures. This is income per person on the horizontal axis. On the vertical axis is total healthcare spending. Who's the yellow, top right, who's the yellow bubble? That's the US of A. Just above it, you can't see it very well, but just above it is a tiny little bubble. So with total healthcare spending very high, but total income per person also high, but a smaller country, is Monaco. And I think, although I don't know for sure, that this is Canada, the little red dot, but I'm not sure. So you might imagine, here we are, a nation of great wealth, spending a great amount of money on healthcare. What do we get for that? Legitimate question for you. Here's some of what we get. We get bottom third of life expectancy among developed nations, 78.2 years compared to Japan at 83. We get 4th highest infant mortality rate, 6.5% compared to 4.6. And among 7 nations, developed nations, we're first in obesity. Is CME at fault for that? Is this all CME fault? Probably a percentage of it is CME fault. It's debatable. Were this a workshop and we had flip charts and I could engage you even more, we might have thoughts about where effective continuing education might play a role. So what do we know about effective continuing education? Well, we know a lot. This is, I entitled this slide, Paying Attention to the Research. This is quite embarrassing. This is when you can get all your entire research career on one slide. It's pretty humbling to you. But let me share with you some of what not I've learned from my own research, but my colleagues at the Cochrane Collaborative and with AHRQ and elsewhere have learned. So point number 1, physicians and others are not so self-aware. We need data to tell us how we're performing. If you asked me, how are you doing with your I was a family doc for 40 years, how are you doing with your flu shots and your mammography rates? I would pretty much indicate 75%, 80% compliance. It was always less than that for a variety of reasons. So we're not self-aware, number 1. Number 2, knowledge is necessary for us to change behavior, but clearly not sufficient. So what works? If didactic lectures don't work, what does work? Interactivity works, and sequencing and some other things that I'll share with you in a minute. If there's nothing else you take away from this, I want us to think of CME as more than conferences. So think about how we learn about things. We learn because we treat patients and get feedback. We go to the electronic health system and we see a reminder there, maybe something we've forgotten and need to be reminded about. We talk with our residents. We meet a colleague in the hallway and we talk to them and we learn a little bit more as we're doing that. And we go to the conferences and we read the journals and we do some podcasts. So CME is greater than conferences. And if we think about it in this sort of wraparound fashion, then CME becomes almost like that air that we breathe. And lastly, docs pass through stages of learning. So think of the last clinical practice guideline that you encountered and which you now adhere to. The stages we pass through are awareness of the guideline, agreement with it, adoption of it, that is maybe somewhat sporadically, and then adherence to it wherever we think it should be applied. Thinking that lectures change behavior is a pretty dumb sort of thing. So here's some dumb things. The Alton attorney accidentally sues himself. I really like that one. I like this one. Statistics show that teen pregnancies drop off significantly after 25. They're surprised it took that long to drop off. And lastly, this is no joke. Somebody to go back in time with me, this is no joke. You'll get paid after we get back. Must bring your own weapon, safety not guaranteed. I have only done this once before. So there's some dumb things. Thinking that by giving a lecture, I had a very good friend at the University of Toronto who was a brilliant lecturer in lupus. Every year in the 4th year he gave a lupus lecture, and then subsequently for 10 years people, family docs and general internists, would refer him lupus patients. And he'd say, you know, they don't do the right things. It's as though I hadn't lectured to them. So thinking that a lecture is going to change behavior is fairly dumb. But we can make lectures better. Here's just some ways of making lectures better. And I'll talk to this in the space of talking about grand rounds as a vehicle for change. So we can add questions and answers. We can do pre and post multiple choice examinations. We can do case discussion. We're all little Dick Tracys and we like to solve a problem. We can do audience response systems. We can think about an answer quietly to ourselves. We can share with our neighbor, and we can do it in small group work so that even a group of 500 people can be made into small groups much more effectively. And there is very clear randomized control trial evidence that these things work. There's also randomized control trial evidence about these sorts of things. Audit and feedback, for example. This is from my colleagues in my study in 1995. I keep on dragging out the slide, although the studies have been replicated and the systematic reviews have enlarged. The proportion of change compared to numbers of studies has not. So just think of the proportions, not the numbers down below. So about 50% of audit and feedback will change at least one measure of clinician performance. If the audit and feedback are done directly, that is, my group compared to a group of my peers, or myself compared to my peer group, and done within a fairly short time period, like 3 to 6 months. Reminders are pretty potent if they're one reminder at the point of care. They could be electronic or paper, generally electronic. Oh, thank you. Yeah, thanks. Reminders are pretty potent. You can tell the proportion of those studies that use them compared to those studies that changed at least one element. However, the more reminders, the more decay. So at about, in my last clinical practice, if I had more than 3 or 4 reminders, I tended to turn them off. Patient-mediated strategies. Here's a question for you. Is it more powerful to remind the patient about her mammogram or the physician about the need for her mammogram? It's more powerful if we use the patient in a meaningful way and alert her to the need for the mammogram. Something to get us thinking about patient education, maybe. Opinion leaders. These are individuals who are embedded in a clinical setting, like a ward, for example, who are change agents within that community or locally based setting. These are quite powerful change agents. There are many more studies of them. Academic detailing, outreach for prescribing behaviors or preventive behaviors, for example, fairly powerful. You can tell how conferences are. So conferences, particularly the didactic ones, not so potent. You can tell how popular I'd be talking to my CME colleagues across the country, right? And print and audiovisual material about 40% of the time when it's interactive and when it's blended with other activities. There are lots of other things to think about, however, in this space. So they include the iPad and electronic communications, about which there's growing evidence. Apps, for example, at the point of care. Team-based training, interprofessional education. Mentoring, I mentioned academic detailing to you briefly. And lastly, simulation. So thinking about simulations, not just in the high-tech space, like I've described here with this picture, but in fact in the low-tech space. Communicating end-of-life issues, for example, is much easier after doing it with a standardized patient than it is to try at full bore on one's own. So what are the forces changing CME? I think we're probably all aware of the reports that have been written about the need for change in healthcare, the quality chasm, the health professional education. These are IOM reports, comparative effectiveness, the evidence-based medicine and guidelines. The IOM has been very active in this space. This is the Macy Foundation, Patient Care Safety Foundation. So I could easily have built a slide with another 100 or so. There's something to be said about these. Some of them are very negative. One called Unmet Needs by the Patient Safety Foundation was very critical of the AAMC and the medical schools of the US. But I think there's some merit. Here's the merit. This is Leonard Cohen. There's a crack in it. That's how the light gets in. Clearly there's a crack in how we've been training undergraduates, graduates, and maybe allied health professionals. Clearly there's a crack in how we deliver care. And some of these reports have let a little bit of the light in. And there's also for us a plethora of changes that are coming down the pathway at us at a fairly rapid clip. In the regulatory space, the Joint Commission, the ACCME requirements, the new ACCME requirements for quality improvement have all moved us in a direction towards driving education towards healthcare outcomes. The quality improvement and performance improvement initiatives, information explosion, electronic health records, HIT in a general sense, transparency of reporting, the Sunshine Act. If you had told me 5 years ago when I came to the US that somebody would shine a bright light on commercial support, I would have said you were crazy. But look at this, we have a Sunshine Act that now shines a bright light on commercial support of educational activities. There's a very large research agenda called the Implementation Science Agenda. It's been embraced by AHRQ and the NIH and embraced now by PCORI, the Patient-Centered Outcomes Research Institute. In Canada, that field is called knowledge translation, and it has transformed much of what we think of and how we think of it in a scholarly way about delivering information at the point of care in a meaningful fashion. There's new diseases, there's outcomes-based education. So thinking about less time-based education in continuing education also gets us thinking about less time-based education in undergraduate or graduate education. And that movement is called competency-based learning and assessment. So imagine moving a medical student, maybe with nursing as her background, moving through medical school in 3 years instead of 4 years. So we're beginning to think about that and beginning to experiment in that area. And lastly, two things to think about that have to do with research about continuing education. There's very clear research about what's effective in continuing it, and there's increasingly continuum studies. So from Tamblyn, particularly at McGill, thinking about the impact of undergraduate education on practicing is not something that we think about very often, but it does have an influence, and there are some studies that have tracked it. So let me tell you briefly, just as I wind up, a bit about what we're attempting to do in this space. It's obviously an inadequate step. It's one small step at a time towards helping the academic medical centers of the US and Canada make some of the changes that I've talked to you about. So this is a slide that exemplifies one small step at a time. My doctor told me to start my exercise program very gradually. Today I drove past a store that sells sweatpants. I like that because I think, well, he's made a step, right? So this is about the Aligning and Educating for Quality project. Here's the situation that I see when I'm very lucky, by the way. I get to visit the medical schools and teaching hospitals of the US and Canada. It's a great job. And here's what I see. It doesn't look like silos exactly, but it feels like it. So over here, I've exaggerated the two silos so you get a feeling for what they're like at their extremes. So here's the CME operation over here, or the medical education operation over here. In CME, at least, the focus on courses and conferences, frequently, although less frequently, dependent on commercial interest and self-assessed needs. So the traditional model there would be, we get a little grant from some company, name a company, Merck or somebody, and we get a group of docs sitting around a table, usually at the end of the day, and they say, so we have to put on our big annual day in big toe disease, for example. Who do you want to hear speak? As opposed to something else. I'll tell you about something else in just a minute. And over here is this silo, which is the clinical care enterprise, focused on quality metrics and costs and clinical care delivery and patient satisfaction and all the other things. So the goal is to bring those two things together. That's the goal of aligning and educating for quality. What do we do? It's a three-part process. It's partly consultation about educational activities. So helping the CME provider deliver a more effective and integrated educational program. I'll tell you a little bit more about that in just a minute. It also uses all the means at disposal, not just the conference. So it could be team training or electronic health records reminding. The next thing it does is consult on the organizational alignment of CME. So often the CME, I used to say CME is more often in the basement than not. It's not here, but oftentimes it is, both metaphorically and physically in the basement, unrelated to graduate medical education or quality and performance improvement initiatives or faculty and staff development. And lastly, it provides resources. So for example, several of our sites have embarked on a cross-system initiative in VTE reduction or blood product use reduction or sepsis control, and we provide online references, funding sources, templates, teaching tools, slides, checklists, wherever the school points us to or wherever the needy academic medical center points us to. Here's what we call the cycle of improvement. So I talked to you about quality improvement in education. Quality improvement, the data sources represent utilization data, comparative effectiveness research results, OPPE results, whatever data the department or the division or the academic center creates, and marrying them with grand rounds or team or staff organizational development. So the planning isn't done by individuals without any data. It's done by individuals who have data in front of them and can say, here's the clinical care guide, here's where we should be, here's our benchmark for congestive heart failure readmissions, and here's where we are. How can we get up to the benchmark? The process is putting those two things together. So using quality to drive those rounds or morbidity, mortality conferences or team training. The feedback is two parts. One is feedback from the learners themselves, the practitioners themselves, but most importantly from the quality data folks themselves, which then gets fed back into it. So that's the little cycle that we use. And this is the typical academic medical center. It reminds you of when I was a kid, my father gave me an old watch and I took it apart and it looked kind of like this. I never put it back together again. And we all know that these cogs exist: the medical school, the faculty development enterprise, the undergraduate or graduate, the practice plans, electronic health record. And somebody at the dean's level or the CEO level is beginning to think about putting these pieces together. But rarely do we think about CME and CPD in that space. And were it better aligned, it can help, not that it takes over the others, but it can help the others move more critically or better. And I'll share with you the ways in which we do that. This is just to give you the URL for MedEd Portal, which is our online learning resource where many of these resources live. And if there's time, I'll tell you more about that. We had I came to the AAMC in 2007. It took me about a year to find the bathroom, and then it took me a year to figure out the American system compared to the Canadian system. And then I was able to propose something, and what I proposed was this, the aligning and educating for quality. And we were lucky enough in 2011, maybe late 2010, to find 11 pilot sites. That's a list of those, And we chose them based on their interest and readiness and the existence of champions and their capacity to make change and the desire to pick out clear metrics like the VTE rates in order to make those changes. The yellow, they're not quite yellow, are they? They're something like yellow, are the 11 original pilot sites. We've now added, have signed on all but 20, so maybe 19 new sites. This slide is slightly out of date. So we'll be close to, by the middle part of 2013, be at 30 sites. And Aligning and Educating for Quality in Mount Sinai is now one of those sites. Were those sites successful? So I'll just talk to you about the 11, and I'll share with you some of their findings. So the most important are those that belong to the Academic Medical Center. I've divided this slide into Academic Medical Center outcomes, our metrics, that's AAMC, and lastly, joint products. The most important one of which in 3 of our centers has been patient care improvements. I mentioned VTE rates, and with a concerted effort in the educational space, interprofessional educational space, the VTE rates in that one center are now back to where they were, that is down to where they were, and below to a statistically significant extent in 9 months. In 6 of our 11 sites, there's been a realignment of continuing education with some of the organizational entities. More often than not, a joint committee of performance improvement, QI, patient safety, and continuing education. In some, it's been a marriage of offices, but more often than not, it's at the committee level. And lastly, in 10 of the 11 sites, and some would say 11, we've developed champions at the leadership level. So somebody now at the dean's level, vice dean of education, who understands the value of continuing education when married with quality improvement, and even more importantly, on the clinical side, the chief medical officer saying, there's a gap, we need an intervention. Let's turn to our continuing education folks to see what they can do. We've also developed new resources to help the education. We've developed 2 publications now in press, and we've developed markers of organizational readiness, or a survey to help us understand, the sites understand where they are. So I just thought I'd give you an example. This room looks a lot like this room. So this is self-assessment grand rounds. So that's a little committee that helps plan the self-assessment, that plan the grand rounds for the department of, name a department. And we've invited in, for this occasion, somebody from the UK who's done wonderful research in areas that are somewhat related to what these folks all do, but not totally. And here's what goes on inside the heads of these individuals. Maybe he's talking about diabetes, and he's thinking, gee, I have a diabetic patient with ketoacidosis. I wonder if that's the patient on 5A. Maybe I should go visit that patient. This person is thinking, my charts are overdue. This person is thinking about her teenage children, don't we all? A golf game this afternoon. I don't know what this guy's thinking. He's got a blank sort of thing. Now, supposing those grand rounds focused on quality metrics, division of, name a division. Here's our metrics for this last 3-month period in cardiology division, congestive heart failure, readmission. Supposing it was that, and that's what this individual, local individual, was talking about. Our department's performance in disease X management. Somebody might say, what's the evidence? Somebody might say, how do we compare with the hospital up the street or another division, for example, with readmissions rate? How could we do better, this individual? She's not thinking of her teenage children any longer. What's the role of other team members? It's not just my fault. It's not just my fault or my team's fault. What do the other team members do in this space? So I wanted just to share that with you, not that this happens universally, but the more focused we are on our behaviors, the more the performance gap is portrayed in front of us, the more concentration, I think, that we give something. This is, I'll just share this slide with you. It's almost the last slide. This is called putting it together. So what I've talked about are individual activities within departments or divisions. But one can imagine a system-wide activity to improve, say, communication about end-of-life decision-making, across the system, or improve sepsis, or another topic of interest to your system. How do we do that? Well, how do we think about those things using the research that I talked to you about earlier? Remember, we talked about awareness, agreement, adoption, and adherence. Those are the stages physicians and I'm sure other health professions, maybe all humans, go through. And then we talked about predisposing, enabling, and reinforcing. So we can predispose to a change, we can enable the change, and once the change has started to be made, we can reinforce it. So if the issue is awareness, if this is a new metric, a new guideline, a new finding that we have that our congestive heart failure rate is in fact that bad, then maybe it's all right to do a newsletter or grand rounds or something more didactic. If we wish agreement, however, that that is our problem and we need to buy into it, departmental rounds or meetings or small group or team-based discussions or champions might enable and predispose to the change. If the issue is we're aware of it, we agree with it, but we haven't really started to do anything about it, then maybe that's another role for a different form of CME, workshops or maybe simulations. And lastly, if we've begun to do it but need support in order to adhere to whatever it is more thoroughly, then reminders, audit and feedback, maybe pay for performance, quality measures fed back in some way meaningfully to the physician and or his team. Maybe those are powerful tools for us. So this is your part. This is, so what? What are the implications for Mount Sinai? This is a bit of Canada. This is the Fraser and the Mackenzie Rivers. Anybody been there? Northern British Columbia? So the Fraser and Mackenzie look quite different. One is quite slate-like, sort of gray, and one is brownish, more mud-like. And after they've come together for about half a kilometer, you can't see it very well here, but they become an amalgam of the two colors. It's almost impossible to tell which comes from which. And so instead of thinking of CME as this discrete sort of stream along one side and quality improvement as this other discrete stream, what I'd like us to begin to think about is how we can put them together in a meaningful manner. And I'll conclude with this. This is the obligatory Canada beat the US in the 2011 World Cup. So I'm obliged by the Canadian government to put this slide on at any time. This is more about the AE4Q initiative and many of our other initiatives. It's my email, of course. And the resource at the AAMC called MedEd Portal that lives on that particular domain. So I'll stop there and ask for questions.